we will present a case of a 42-year-old male. He is complains from acute visual weakness of his left eye. 3 months in his medical history, 3 months previously he had suffered from an ocular trauma by a stone, causing a penetrating corneal wound on his right eye. The wound was surgery in initial time, and his right eye underwent other 2 surgical treatment operation to extract foreign body by a stone, but we don't have success to extract. In examination of this patient in the right eye, we have no light perception, and the globe is in a state of phthisis, and we see the foreign body in the orbital scanner. In the left eye, we have the best corrected visual acuity was 2 from 10. There is no signs of inflammation on the anterior segment. The lens was clear, and the posterior segment we note the trites, papillar edema, and exudative retinal detachment. That is more showed on optical coherence tomography. The diagnosis is clinical. We are in front of ophthalmic symptomatic ophthalmia. We start the treatment for a high dose of methylprednisone, and we relate by 1 milligram per day prednisone was initiated and then tapered slowly over 6 months. The evolution was made of resolution of the exudative retinal detachment, and the best corrected visual acuity improved from 2 to 4 from 10 and remained stable. To say that symptomatic ophthalmia is a rare bilateral granulomatous uveitis, it's usually associated with perforating injury. The injured eye is known as the exciting eye, and the fellow eye as the sympathizing eye. The onset of this disease varies from a few days to decades. It varies from 1 week to 66 years, 80% within the first year. The exact cause is unknown, but believed to be related to autoimmune response. At initial onset, the main clinical findings are located in the posterior segments. We will show the optic nerve swelling, moderate or severe vitritis, and an exudative retinal detachment. We can see a granulomatous anterior segment inflammation with mutant fat keratic precipitate, choroidal infiltration, and these nodules, yellow and white, called the Dallen-Fuchs nodules, that are typical from symptomatic ophthalmia, but not pathognomic of this pathology. The evolution of this disease the patient can experience recurrent episodes of exacerbation. The most complications are secondary cataract and secondary glaucoma due to the corticosteroids, chronic maculopathy, retinal detachment, retinal atrophy, choroidal neovascularization, and optic atrophy. One rare case, we can see extraocular symptoms like hearing loss, headache, vitiligo, and meningeal irritation. The corticosteroid therapy is the first-line therapy after the onset of symptomatic ophthalmia. We initiate the treatment by 1 to 200 milligram for the first week, and after we reduce by 5 milligram per week, and we maintain a dose of 5 to 10 milligram per day. If we have an improvement of the inflammation, we can continue the corticosteroid for more 6 months. If there is an intolerance of corticosteroid or a lack of response, we will add an immunosuppressive therapy like as cyclosporine A, azathioprine, or methotrexate. Other treatments are described in the literature, like intravitreal injection of triamcinolone acetonide or the fluocinolone acetonide implants. Although corticosteroids are very effective in the treatment, the corticosteroid cannot prevent the development of this disease, and the only known prevention is the enucleation of the injured eye before the onset of the disorder, and you must see that all eyes with any potential vision should be, of course, not enucleated, because the exciting eye may actually retain better vision than the sympathizing eye in the course of the disease. To conclude, to say that sympathetic ophthalmia is a devastating granulomatous inflammation. It can lead to bilateral blindness unless a systemic immunosuppressive therapy is initiated in the early stage, and the early signs and symptoms of this disease must be carefully watched for. Thank you.
Thank you for this excellent presentation, for your excellent English, excellent pronunciation, and we thank you to respect time. Is there any questions in the audience? No questions? Your patient had just a corneal wound, not scleral wound?
Just a corneal wound.
Yes, usually we say that the risk of sympathetic ophthalmia is more when there are scleral or wound, but we must be conscious that it is possible even after a corneal wound or just a chemical burn. Thank you.
We pass to the next alcohol doctoratia to Cam presenting her case.
Hello, Mr. President, please. Dear Master, dear colleagues, allow me to present the new case report compiled in our ophthalmology department of ATMO monastery. A 30-year-old female patient complained of vision blurring of the left eye for 2 weeks. At presentation, best corrected vision acuity was 20/20 in the right eye and 20/80 in the left eye. Examination of the right eye was unremarkable. Examination in the left eye was showed no anterior chamber cells.
Still close to the
Examination of the left eye showed no anterior chamber cells and 1+ cells in the vitreous. Left fundus eye showed a subretinal elevated yellow-white lesion that was 2 diameters in size, located inferior to the optic disc with overlying telangiectasia and associated with exudative retinal detachment, papular hyperemia, and macular exudates. Fundus fluorescein angiography of the left eye revealed an undefined subretinal lesion with early hyperfluorescence and late hyperfluorescence. Spectral domain optical coherence tomography for the left eye showed subfibular nervosensory detention with serous retinal detachment and epiretinal membrane. Ultrasonography shows a moderate internal reflective mass. In the initial workup, chest X-ray was normal, tuberculin skin test was strongly positive, search for acid-fast bacilli in sputum and urine were negative, syphilis serology was negative. The diagnosis of vascularized choroidal granuloma of presumed tubercular origin was made. The patient was treated with antitubercular treatment combined to a single intravitreal bevacizumab injection. After 6 months follow-up, patients still on antitubercular treatment, best corrected visual acuity of the left eye at 20/50. The size of choroidal tubercular granuloma was reduced and subretinal detachment fluid has resolved. The spectrum of ocular tuberculosis is wide. The most common findings include vitreitis, posterior synechic, multifocal non-centroid or centroid choroiditis, and peripheritis. Choroidal granuloma is a rare feature of ocular tuberculosis, which usually manifests as a large, solitary, elevated yellowish subretinal mass that may mimic a tumor. Loss of vision may be secondary to the exudation caused by the vascular component. Intravitreal injection of bevacizumab, while the patient receives antitubercular treatment, may be helpful in the treatment of choroidal tubercular granuloma and associated exudation. Thank you.
Thank you for.
Thank you. So I'm going to present the the case report of bilateral scleritis revealing ganglionar sarcoidosis. It's a case of a 34-year-old male smoker with no medical history who presented for bilateral recent eye redness with mild pain and blurred vision. The ocular examination found a visual acuity of 8/10. The scleral examination showed a diffuse non-nodular scleritis with dusky hue, especially in the left eye, as you can see here. The cornea was clear in both eyes. The examination of the anterior chamber showed moderate inflammation reaction, grade 2. The irises showed no synesthesia. The pupillary reflexes were boosted. The lens is clear, the vitreous skull. And the examination of the dilated fundus found normal optic discs and maculae. The fluorescent angiography was normal in the left eye, while in the right eye it showed peripheral segmental periphlebitis and peripheral capillary diffusion, as you can see here. Biologically, there was no inflammatory syndrome. Tubercle IDR showed energy, quantiferon was negative, as well as syphilis serology, ACA, and anti-DNA. The dosage of angiotensin converting enzyme was significantly high. The chest X-ray showed mediastinal adenopathy, confirmed in the chest CT scan. The bronchoalveolar lavage and biopsy were both negative, and we proceed to thoracotomy, and the biopsy of the lymph node showed no caseated granulomas. Thus, the diagnosis of sarcoidosis was confirmed, and the treatment consisted on a local and systemic corticosteroids at a dose of 1 mg per kilo per day, with complete regression obtained. So, what about scleritis and sarcoidosis? Scleritis is associated with a systemic disease in approximately 40 to 57%. Rheumatoid arthritis is by far the most common association. Followed by relapsing polychondritis, systemic lupus erythematosus, arthritis with inflammatory bowel disease. The scleritis manifests bilaterally in about 50% of cases. It's seen more commonly with patients with underlying systemic diseases. The extension of scleral inflammation to the anterior uvular tract, like in the case of our patient, could be the consequence of a more severe disease with possible ocular complications that might cause progressive visual loss. The occurrence of anterior uveitis in the course of scleritis entails a poor prognosis in 40 to 50% of cases. Ocular involvement in sarcoidosis is common, although anterior image pathology can be observed. Up to 85% of patients with ocular sarcoidosis, scleral involvement is rare. Scleritis has been reported in less than 3% of ocular sarcoidosis patients, and scleral involvement is often an asymptomatic nodule. Scleritis is not considered as an ocular criteria to diagnose sarcoidosis according to the first international workshop on ocular sarcoidosis, but it should be invoked as a differential diagnosis in patients with bilateral anterior diffuse or non-nodular scleritis, as reported elsewhere in literature in few cases in 2009. As for the treatment, it's based on systemic corticosteroids at a dose of 1 mg per kilogram per day until inflammation is correction. Then we proceed to cell regression. Thank you for your kind attention.